Hello and welcome to the Rural Doctors Programme. I'm Jerry Gannon and thanks for your company tonight. Well, our programme this evening focuses on Indigenous health and the format of the programme is a little different. We did have the option of a panel here in the Perth studio or going out to talk to the people living and working in remote areas. So tonight we have no panel in the studio and unfortunately that means you won't be able to phone in to question the participants. However, we did manage to talk to and get advice from many health professionals working at the coalface of Indigenous healthcare. Tonight we'll hear from the team at the Ord Valley Aboriginal Health Service about the importance of good data management in addressing chronic disease. We'll also talk to the team at the Broome Region Aboriginal Medical Service about their population health programs, in particular the role of Aboriginal health workers, and we'll drop into the Kimberley Satellite Dialysis Centre. We also intended to bring you a segment about hearing testing, but unfortunately we can't bring you that story tonight. Instead, we'll look at the work of the Ord Valley Aboriginal Health Service Social Support Unit that was set up a year ago to provide an avenue for appropriate referral. But first of all, we asked Dr. David Atkinson, the medical educator for the Kimberley Aboriginal Medical Services Council, and Dr. Alex Balzarelli, medical coordinator for the Rural Clinical School, to give us their views on where we're currently at in providing care to Indigenous people and to give us their advice on what each of us can do to improve access to healthcare for the Aboriginal population.
The change of government that happened late last year has certainly made a few changes in perception. It's been important for Aboriginal people in a lot of places that there's been an unequivocal apology from the government, and there have been suggestions that policy is going to change and perhaps better reflect the needs of Aboriginal people. I guess we have to wait and see as to how effective those changes in policy are, and we haven't actually seen anything on the ground yet, but it is still early days.
Knowing and working with a lot of Indigenous people, that is the feeling that they are reflecting, that they think it's been a wonderful, positive move and that the wave is starting to ride high on the hopes and optimisms and that things might finally get better.
Having been working in Aboriginal health for 25 or more years, I guess we've seen lots of ups and downs in expectations. So I tend to be a little bit cynical until things are actually delivered. So I have high hopes, I'm positive about it, and lots of other people are positive about it. I think it could possibly lead to significant improvements, but until there's actual delivery of large amounts of resources, things are going to change very slowly.
We all feel so helpless, really. A lot of us don't have contact with Aboriginal people, or if we do, we find it very difficult, or it's a very transient relationship, particularly if we have Aboriginal patients and we've not spent much time with Aboriginal people. In fact, there's no easy answer. I think it's about literally spending time with Aboriginal people, because that's how you learn about them, read about them, read about stories, read Why Warriors Lay Down and Die by Richard Trudgeon. It's just being aware and caring as a first point. The second point is to try to get to know some Aboriginal people, because it's the process of being with people is how you will learn about them. In particular with Aboriginal people, they have to actually get to know you. So on your first consultation, probably nothing much will happen. It's about relationship building, and that's on a one-to-one basis. If you have some Aboriginal patients and you're wondering, I don't seem to be able to help this person, it's just about seeing them and giving them time.
Yeah, I think in ordinary country general practice, you get to know your patients pretty well. And if you work closely with Aboriginal people, you also get to know your patients pretty well, but it takes a bit longer because the cultural distance between the person providing the care, the GP or the other people working in health, and the patient is greater, the different understanding, the different background. So it takes longer. And that's a really important lesson. So you've got people from a different culture, it takes longer. You might need a translator, you might need a support person to help bridge that cultural gap. This applies to pretty much all of your Aboriginal clients even people who you might think are fairly, well educated, speak English well, there are still very different family and intergenerational experiences that mean that it takes quite a bit longer to get to trust some strange outsiders who's just come into their community, or someone who's been there for 5 or 10 years but they've never really got to know them.
People feel much more comfortable when they are around people that they feel they get on with or have something in common with. So simply employing an Indigenous person in your workplace, in whatever fashion, reception, admin, nurse, whatever you can manage, will make a wonderful step in the right direction to make your Aboriginal patients, it's making a statement, and your Aboriginal patients will feel much more accepted walking into your practice. Another thing you can do, although this is taking time out from your life, is the first time I ever got to know, I've been brought up in Perth, didn't know any Aboriginal people until about 10 years ago. I went on a bush trip with Jeffrey Stokes and Christine Jeffries Stokes, and just camped with Aboriginal people for 2 days, and that's when a penny dropped. So if you could go on a camping trip, if you could just get to know some Aboriginal people in some way, it's a great step in the right direction.
There are some examples of application of resources. Obviously the big ones are in areas like housing, education, employment, enterprises, and all of those sorts of things that underlie ill health. But in health services in particular, the provision of extra resources for remote communities makes a really big difference. And we've got some examples of initiatives actually under the Howard government where there was for a while extra resources in Aboriginal health in areas of the Kimberley, and that has already made a significant difference in the management of chronic disease in places that have got the extra staff, the extra medical visits, the drivers and health and receptionists and other staff to support programs. Bidjadanga, Balgo, places on the Dampier Peninsula have all had an improvement in services through what was the Primary Healthcare Access Program of the previous government, which they then subsequently stopped without rolling out everywhere else. And it does make a difference, and we're sort of working on that, but it takes time, and we've only been working on it for a few years, and policy changes every 2 to 3 years, so you grab money while you can.
General measures that I think are absolutely vital. I'm just repeating really what David said. Housing, education, simple things like provision of swimming pools. We know that improves ear health, and programs like what is it if you don't? No, you're not going to school. No pool, no school. Yep, no school, no pool. And even simpler things like subsidies of healthy foods. Did you know a sweet potato in Fitzroy Crossing supermarket costs $17? One sweet potato. That's a large one. How can Aboriginal people afford fresh fruit and vegetables and healthy food? You've got to start with simple things like that.
I guess the implication of those sort of programs is if you have the capacity to follow up chronic diseases through having additional nurses in practice, in our case, employing more Aboriginal health workers, but it's more generally applicable across the community. A lot of the issues we face as GPs these days are the better management of chronic disease, and without the team of workers to work with the doctor, we're wasting resources very often in not following people up, not following things through because you're waiting for people to come through the door. Being proactive is something that the rest of the community can actually learn from Aboriginal health.
Health is a many petaled flower. We know that it's psychological, spiritual, mental, physical, and social and economic. That all of those factors will give you good health. And for a lot of Aboriginal people, they have a sick spirit because of all the things that have gone on before them, the stolen generation, the dispossession, the poor economic circumstances, and therefore the problems with alcohol, drugs, domestic violence, and so on, and crime, high rates in prisons. That is the whole picture. And until we look at the whole picture and actually start with the seeds of the problem, we're never going to address what we do as doctors, which is really just surface.
Dr. David Atkinson and Dr. Alex Balzarelli there from the Kimberley Aboriginal Medical Services Council. And that's some good advice. But how do we begin to look at the whole picture and address what Alex calls the seeds of the problem? If we move beyond the acute presentation, then we're likely to find underlying chronic disease. But then this chronic disease may have underlying environmental factors and may be complicated by comorbid mental health, drug and alcohol or other social and emotional issues. And all of this is likely to sit on top of the root issues of poverty and dispossession. How do we even begin to address such a cascade of issues? We spoke to the team at the Ord Valley Aboriginal Health Service about how they take the first step to move beyond the acute presentation to try to identify and address underlying chronic illness.
When people come into OVARs, they usually come in for a boil or a scrape on their knee or something like that. And it's at that point that we say to ourselves in the clinic, it's not simply about that presenting complaint. The name of the game is chronic disease. So how do we pick up whether they have a chronic disease? We have a health check. We have a child health check, we have an adult health check, we have an over 55 health check. This health check is simple, it's straightforward for the health workers, for the nurses to be able to complete and for the doctor to then sign off and check all the alerts, or if any alerts come up.
There was a bit of a history of things not being followed up well. A lot of specialists weren't happy to come because they found it a bit disorganised in, kind of 5 years ago. We've got a broad range of programs running now, trying to cover as many aspects of, primary healthcare as we can. We still do the acute walk-in, but we're really focusing on lots of the health checks.
Medicare funded items 708, 710, 704, basically a child health check, an adult health check, or an over 55 health check. When a person comes in, depending on their age, we have a very standardised form for checking their main health issues. By doing this check, that's how we pick up the chronic disease. And it doesn't matter what you come in for, and it doesn't matter what position you have in the clinic. It's our duty as a primary healthcare organisation to not just deal with that presenting complaint, but also think about the underlying causes of the chronic disease. So we're always checking people's heights and weights and blood pressures, just as a matter of due course. So if you come in without an appointment-based system, see reception, pull your file, you see the health worker. The health worker does all those basic vital obs. We're dealing with the unworried sick versus what the metropolitan colleagues, or I feel metropolitan general practice encapsulates sometimes the worried well concept. Indigenous health, we're dealing with the unworried sick, and if we don't screen for the protein, if we don't screen for the sugar, we're not going to find it. Once that information is gathered and we find that there is a potential issue that needs to be sorted out, and it's going to take more than 6 to 12 months, we stick them on a care plan. And that care plan is fairly standard. Our statistics show that for 3,800 regular Indigenous clients, if you're over 45, female and Indigenous, you have pretty much a 50% chance that you're diabetic. So we've standardised our diabetic care plan. We've got the hypertensives, we've got the rheumatic heart diseases. All these chronic diseases have a standardised care plan. The most important part of the chronic disease care plan is the summary that you can see how the HbA1c is going over a period of time, how the patient's weight is going over a period of time. Once you actually work through the first visit, the second visit, the third visit, a picture easily develops on how this person's weight or their ACR is going, or their HbA1c is going, This summary allows a complete clinical picture to develop, but it also provides a summary for Medicare for the cycle of care and PIP and SIP incentive items to say, look, we have actually fulfilled the requirements for a cycle of care. Now, the biggest thing that I found with the media lately is that they've said that the child health checks don't have a follow-up system to ensure that the problems identified are actually dealt with. At OVARS, we feel that if a child has chronic disease or chronic ear infections, chronic skin infections, this entitles them to a chronic disease care plan.
The collection of data is fantastic, but it does need a set person to pull that together and work out what needs to be done. So there has to be a designated person to do that, one person that can focus on that, knows what's being pulled off and uses it effectively. So then in that case, that's me here. That gets passed on then to the chronic disease team, so that they're able to then go through files before the patients arrive, have a look at things they might need to have done. It also gets given to a driver, and anybody that we can ring, we ring.
She goes through every month and pulls up any data entry that needs for any specialist visits, and those who are on the referred from the specialists that come through here, we get a list of those, and we actually go out and we give them times, appointment times, and warn them the date that their appointment is, and then on the day we actually go out and bring them in. Most of the time they're very, very good at coming in. We sit down and explain to them what really needs to be done. They understand and they come in.
But yeah, most people are quite receptive to it. I think it's also really important to explain why you're doing things to the clients. If they just come in and have to sit in a room for an hour having all these tests done and they're not really sure why. So part of our chronic disease health checks is a consent form. So it has to be explained to the patient, explained why we're doing it, how it will benefit them, how it will benefit their health in general, and they have to sign that before we commence the checks. So it's making sure everybody knows what's going on. With the specialists coming in, they have now been able to see that doing their clinics here, they get a better turn up. They're able to talk to someone face to face and hand over information that needs to be followed up on either urgently or in the next month before their next visit. And because we have that information straight away, and again it's about good data entry and good data collection, we can ensure that the follow-ups that they've requested are being done. Whereas previously they were a little unhappy with turn-ups, there wasn't a great number of people turning up, and then they'd often request things and next time they came they still hadn't been done. So yeah, definitely that's all about data collection and data management, and also about good communication obviously between the different health staff. We also use our computer system to pull off numbers to talk to the staff about what's going on, so we'll compare say the last 12 months to the current 12 months of how many health checks have been done, or how much better people's blood results are, like in the diabetics, or which is encouraging to the staff too, because they get to see that they're making a difference. Our numbers have increased rapidly in the number of people who attend the service, which is another good sign. I mean, the guys are obviously a bit tired at the end of the day, but it's a good sign to them to see that the local people are obviously comfortable here and feel like they're getting a good service.
The basic height, weight, blood pressure, and a very quick Google or urine analysis pays dividends. Like, these numbers show that our HbA1c's, our diabetics are under better control, basically. We're getting more people in to be screened, and the people that we are picking up, we're making sure that we recall for their care plan reviews and their checks. Why? Because it improves their diabetic control, but it also allows the organisation to get revenue from the 725s and the 727s, the team care review and the GP management plan review. That's why I believe OVARS is making headways into looking after the Indigenous population of Kununurra.
From when I first started with the health organisation with OVAS, currently ECAP with OVAS, I think they've come a really long way, especially with renal health. They have come a long way. I mean, it's a growing issue at the moment here in the East Kimberley, but it's going to be everywhere. We're just finding new clients, new patients every time we look into the system. So it's something that's going to be an ongoing thing and something that really needs to be looked into. And as far as I know and what's going on, we're on top of it. Yeah, we're actually keeping a lot more track of those people who really need care and the services that we need to provide them with.
The rates of our ACRs, screening for proteinuria, etc., are all have all increased in the last 2 years. Why? Because of the Medicare-driven child health checks, adult health checks, and the over 55 checks. I think that is why the incentive for this organisation to keep on pushing them, keep the health workers and the doctors utilising them, is that by having a simple standard form that all the team members can use, it makes it easier to claim Medicare and also screen the population.
It makes sense that for a population that suffers under a greater burden of disease, a systematic and universal system for screening, tracking and managing the fundamental indicators of health pays dividends. And if you're interested, OVAS have kindly made those various forms you saw for their screening and management processes available. They'll soon be posted on the Rural Health West website. While it's one thing to have a system that flags when a client is due for an appointment, it's another thing entirely to ensure that the consultation occurs. The staff at the Broome Region Aboriginal Medical Service run population health programs with a similar focus on screening for and managing chronic disease. We spoke to them about how they ensure their clients are receiving appropriate care and ongoing assessment, and about the role of Aboriginal health workers in engaging and providing support to the local community.
As health workers, we've got but four health workers here within Broome that go out to these communities and visit the people. And it's good to have these programs because at least these people are getting looked after by their own people, especially health workers.
Was there again, man?
Yeah, heaps of people today, yeah. One driver missing today.
The beautiful thing about community controlled organisations is the health workers are from the community. They've grown up here, they know their client base, and this is where they live, and this is where they'll probably stay, for years on end. Whereas a lot of times, a lot of the doctors, a lot of the nurses like myself, we're here for a short period of time, and although this is a beautiful place, there are other times that we, for various reasons, for schooling or family, we have to move on, and so when we leave, there's a lot of information, a lot of knowledge that leaves with us. So by upskilling the health workers, giving the health workers that valuable knowledge and skills, they continue the work. So it's why it's important that they are adequately equipped and skilled, in the various phases of population health, so that they maintain those programs and that care ongoing. And us as doctors and nurses provide that support role to them.
I'm a local person born and bred in Broome, and I do home visits, go and see the elderly men around town. And there's a place for, we call, an outreach for men. And I go there on a Tuesday, stay a couple of hours, and from there, normally on a Tuesday I take another health worker with me, a young fellow that works at Brown, Jeffrey. So we go all day type of thing, just go home visiting as well. Apart from that, I just normally come back here and go to the first system and just add all the stuff I did on each of these guys that I've seen.
I work for the programs, and I usually work with the chronic disease and pick up antenatal patients and drop off heaps of appointments to people. And I just help out at the front desk, pick up heaps of patients who need to come in from off the books with doctor's order.
And I'll try and offer continuity of carer. And I think the client will more likely continue to follow through with their care plans if every time they come in they do see the regular faces, because they develop that rapport, that relationship with the health service provider, so be it the health workers, because they're the face they see all the time, so they know when they come to Brahms that they'll more than likely, for their diabetes or their hypertension, they'll see the same people, and they've got that trust in those people. So I think it's important that we provide that on a regular basis, and these guys are really skilled and knowledgeable in that respect, as well as knowledgeable and skilled in the community and how the community dynamics.
I know, I wouldn't say all the Aboriginal people within Broome, only the ones that in Broome itself, the local people. But I suppose if you might go down to the Oval and you're looking for somebody, maybe this person maybe from Fitzroy Crossing in Eastern Broome, and you got someone from Fitzroy ring up to say we have to look for this person because he's going to take his medication. Normally what I do sometimes, I just go down to the Oval and there's a lot of people sitting at the Oval, and somebody in the crowd would at least know that person.
Yeah, just chasing them up for their tablets and whatever they need, their daily dressings and stuff like that. We'll try and find them around town. Some are real good, but some are pretty hard to find sometimes. If I can't find them, I'll leave notes there and just tell them to ring me back up when I need their tablets when they reach back home, and I just go and drop them back off to them.
But being a local, you know where to look in that,
Yeah, being local, the hard ones are the ones that come from the communities to find. They're the hard ones to find because they're all over the joint. It takes us a while to find them.
You try and go and look for this individual person that need to be traced down, but within Broome, I suppose it can happen anywhere within Australia, that you might go to one house and then you go to another house, look for one person, probably take you a whole day to go and try to catch this one person. And I reckon with the STI it's the hardest, because if you got people like coming in from other towns and you got phone calls from other AMSs, try to get these acts, ring us up at Brahms and try and find those people from other communities so we can try and find them to have an STI treatment done. And it's the hardest one.
Yeah, there's a few people that doesn't want to come in, and I named one fellow named Tomorrow, because every time I go to pick him up for his daily dressings, he doesn't want to come, and he keeps saying Tomorrow, so now when I find him I just call him Tomorrow and he knows his name from me now.
The health workers who have grown up here, whose family live here and will continue to live here, know the community inside. They know who's related to who, they know who fits in where, and so that information is invaluable, and you can only ever know it by growing up here and living here. So even though I've been here 4 years and I know the community reasonably well, I still don't know to the extent that the health workers do, and some of these senior health workers basically can tell you at the top of their head who lives where and who's here and who's not here.
The health workers within the AMS make it work. That's the link to the community, and without them it would be not that successful at all.
It's hard, with Aboriginal people moving around the country, they're in one town for one week and next minute they're off, it's a hard one.
Yeah. I dropped
the tablets?
Yeah, I dropped it off to the Hanson, and that's here, but he'll come and ask, and he'll come pick it up here.
It is a predominantly disadvantaged and poorer community, so we've got to provide that extra bit to help clients get their medications and get their health care attended to. So we provide as much support as we can within reason to ensure that the clients are able to access their clinics, their specialist appointments, or any other tests that need to be done through means of what we provide, through transport, through organising appointments, through organising regular reminders and things like that. So I think that's the key to what we do here, is going that extra mile to ensure that the needs of the client, the special needs of the client from this community are attended to.
Yeah, I like my job. Yeah, it's good. It's interesting. It's a good job. Yeah. Especially helping out my people. So I don't mind doing what I do. Yeah, it's good. And helping people around the community, anybody, which is a good thing. Yeah.
Yeah, I'd be lost without you. I wouldn't even bother to see a doctor if Brahms wasn't here. Just with the weight and everything that's going on. I've been here a long time. Brahms have been here many years and they've always taken care of me. They bring me up here every day to get my medicine, which I get. I'd have to walk up here without them. I don't know whether I'd be able to walk up here every day. Yeah, I'm very thankful.
At least they know they're getting treated by the people they know and respect, and you have to have that respect for the elders. Going out to them and maybe ask their permission if you're going to take photographs and things like that on them. But I think with them, as patients out there in the community, and we're health workers from Brahms doing home visits, it's a good thing.
I think we're sort of on a good sort of plan altogether and team effort to try to achieve that sort of best outcomes for our patients, and indeed in that way try to close the gap within what we can do here in Broome.
It's the people that we got to try and help them to find, and we didn't have our community programs. I don't think that people would be found so easy, so they wouldn't be getting the help they need. Okay, all right.
Yeah.
Now I can hear you say, yes, but I don't have access to a team of Aboriginal health workers. Yes, the provision of care is obviously different in private practice than in an Indigenous community-controlled health service, but there are some basic principles that can be transferred. As Alex Balzarelli mentioned earlier, there are benefits in employing an Aboriginal person in any capacity at all, because they can immediately increase your clinic's capacity and knowledge of the local Indigenous community, as well as providing a link with the community. And developing strong personal relationships with even a few local Indigenous people can provide an avenue for accessing local knowledge. Another way to ensure that a service is properly accessible and provides culturally appropriate care is to place those services as close as possible to the communities and the country, I should say, of Indigenous people. Moving away from family, friends and home can be daunting for Aboriginal people, to the point where some people will choose not to have treatment. While in Broome, we dropped into the Kimberley Satellite Dialysis Centre and talked to the people there about the importance of having this culturally safe specialist service available to the people of the Kimberley.
The Kimberley Satellite Dialysis Unit has 10 chairs and we work in 2 shifts, but we dialyse 41 patients in total, 6 days a week, Monday to Friday. How this works is a number of patients dialyse Monday, Wednesday, Friday. One group in the morning, one in the afternoon. Then we have another group that dialyses Tuesday, Thursday, Saturday. Again, one in the morning and one in the afternoon.
During Thursday, Saturday and Tuesday. And we do the hours about 4.5 hours, sometimes 5.
Patients that opt in for therapy, we encourage to have peritoneal dialysis as a first option, which is where they have dialysis through bags into their abdomen, because that way they can come straight home. And then we use hemodialysis for the most part as a secondary option. Patients can choose to go straight to hemodialysis. The options are put to them, but most people choose to have the peritoneal dialysis first because that enables them to be at home for as long as possible. The centre came to be because there has been increasing numbers of patients with end-stage renal failure in the Kimberley. The Kimberley, along with the Northern Territory, has the highest rates of renal disease in the world, and the patients that had renal disease were having to go to Perth to dialyse, and which meant they had to move away from their home, which might have been anywhere in the Kimberley, to a metropolitan area, displaced from family, displaced from land, fish out of water. It was very hard for them, and many people chose not to have treatment rather than to have that displacement, and so they died at home.
You know, they don't want to leave the country, they stay home, they'd rather die in their home country. You know, they feel much better in their place. Like even with the holistic care, we was trying to set up a plan, you know, where we get a form for them to sign, you know, when they're too old and too frail, you know, to say that, you know, if they had enough of dialysis, they can just go back to the country and die.
I'm really from Nukunba community. Fitzroy Crossing is my hometown. I was very sick when I went down to Perth and I stayed in Autumn Centre and went to Royal Perth, and I was a bit homesick, but I'm here now in Broome, but we're here now. Good to be with them. Lot of nurses here, they are good. They're all helping.
Some of them they've been telling me stories that they've been down Perth for about 10, 15 years, you know, haven't seen family. Only just because this dialysis unit here open, they get to see family, you know, close to Kimberley's.
We're not just interested in their dialysis or their heart disease or their other medical problems, although that's obviously the focus. That's what we're here for, but we're very much interested in their spiritual well-being, their emotional well-being, their physical well-being. So our focus, our holistic focus, if I can put it like that, is looking after the whole patient. So if that means that we need to intervene in a family situation where people are not coping, we will do that. If that means we have to buy food on occasion, we will do that. We find ways. If that means we have to provide clothes, that's what we do. So the patients feel quite comfortable here to tell us of their needs, because we have this approach that looks after them as whole people, not just a physical illness.
A lot of our funding goes for taking patients back to their communities, especially for funerals or sorry day or any other times where they have to participate. We try and make sure that there's always enough food in their houses. We look at if the family needs any help. So there's a team of people working together to provide this holistic nursing.
Like when they have funerals, some like certain food they can't eat. Some people don't even eat meat for a year. They just have fish, you know, they just keep eating fish. That's its cultural way, you know, having the side of it. Yeah, it's all different, you know, just a lot of people don't understand it, you know, and like mother-in-laws, you can't talk to your mother-in-law. Or, you know, you get some people here, they couldn't come to dialysis at the same time. They couldn't be seen together. Like if one person had to be on one side and the other with the curtain closed for one to move first, you know, or go around the other side of the building.
It's good, you know, good to have people like that and working and being friendly to us. Yeah, Brahms is good. Communities working together here.
We have patients who are non-compliant at times, but when you look at the figures over a number of years, we've had 95% plus attendance, which is pretty good, and I think contributes to good outcomes. But why do we have a good attendance rate? I think because it's a culturally friendly, homey environment. We have drivers who go out and pick patients up and deliver them home afterwards. It's a small environment, so if patients don't come, they're missed, and obviously Broome's quite small, so if they're not at home, there are places they might be that we can go looking, and we do go looking within reason.
When I, you know, put them on the machine and, you know, they turn up for dialysis, it make me feel good because they're getting good treatment, you know, not missing out, prolong their life. I mean, I even get worried because some of them, they miss out, and because in the Aboriginal way you get worried, and you feel no good, and we try to wonder where they are, or, we ask a lot of people if they miss out a lot of dialysis. A lot of people don't want to send them back to Perth because that's not their home is here, then, up north.
Initially, there were about 30 patients on the waiting list in Perth, and we thought we'd have plenty of space, but as I said, very quickly we filled up to our 40 patients, and now we're back in the same boat we were in back in 2004 with the same number of patients waiting. We've got about 28 to 30 patients waiting in Perth to come back.
The Kimberley is probably twice the size of UK itself, and the amount of patients with renal disease is the biggest in the whole of Australia. So in order to accommodate all the treatments with the treatment number of the disease, an expansion is going to have to happen.
We have a business case before the government to increase the number of haemodialysis chairs available in the Kimberley. We're hoping to have 24 places available in Derby and 8 in the first instance available in Kununurra, which will enable people to get closer to home again, and it will then enable us to bring more of the patients waiting in Perth back to the Kimberley.
When we go back home, we need to go back because we need to go. So we need to have our own dialysis back in our own community, where we come from. I'm from Nukumba. I need to go home, and the rest of the people who are now in this dialysis with me this afternoon. So we're thinking to go home and have our own trainer and carers.
Renal disease is in epidemic proportions. It's rapidly increasing in all populations, not just in the Kimberley. It's often missed, it's often picked up late, people present late, which decreases their chances of having good outcomes. I think it's very important that GPs have renal disease high on their index of suspicion, if you like. Renal disease is very easy to screen for. When a patient comes in for their stubbed toe, do a blood pressure, do a urinalysis, do the health check that you actually get a rebate to do. Have it on your mind that you want to treat patients holistically. You don't want to just treat the stubbed toe or the sore throat. You want to treat them as whole patients. So you need to screen for a number of different diseases, but obviously particularly I have a renal focus and chronic disease in general.
I've more been back in communities, trying to talk to them, because I need to correct not only me, but I like to correct the younger ones who are getting sick. But they will beware of getting sick because they might be dialysis maybe any time.
If you want to have a healthy patient, then you have to have a look at what the nursing profession has always said, the whole approach, the whole body, the family. If that is not healthy, if that doesn't function, then your patient won't be compliant with coming. They won't be as well as they can be. All these factors should be part of healthcare, and that's what we practice here.
Obviously an area where there's real demand for services, and it's so good to see that specialist services can be provided closer to home without compromising clinical care. So we've looked at the management of chronic disease like diabetes and kidney disease, but what about other areas of chronic health problems, mental and emotional health? Substance abuse, mental health problems and other social and emotional issues can sometimes be the elephant in the room when in a consultation with an Aboriginal patient. The absence of appropriate places for referral represents a huge hole in the net of systematic, holistic primary health care that we've seen tonight. Well, 1 year ago, the Ord Valley Aboriginal Health Service set up a social support unit that operates alongside the primary health clinic to close that hole in the net of care.
Well, the social support unit is part of OVARS, and it was actually started a year ago, and the reason that it was developed was to try and fill a gap for Aboriginal people that's existed for a long time. The gap being that Aboriginal people didn't really have sort of like access to drug and alcohol services. There's a lot of domestic violence, suicide and so on, like sort of mental health problems that don't actually come under acute or chronic mental health, but are still like have a bearing on people's well-being.
Its basis was to allow an Indigenous controlled health organisation, an ARCHES, to have some control over the mental health issues which are endemic in this area.
Everybody knows mental health issues are huge in remote Aboriginal communities and towns that are majority of people are Aboriginal. You know, we see it all the time in papers, suicide rates are higher and, you know, alcohol use is higher, and not having an adequate and a safe and comfortable place for them to go and be seen about that is a huge gap in their health provision.
I do see a lot of mental health issues out there which are preventable, and if need be, you know, we can refer them to the Northwest Mental Health here, and they'll further their counselling with them or with medication. At the social support, we mainly deal in counselling with a counselling service. We don't give them medications or anything like that. They have to be referred to the doctors here or mental health. But over the years, I've noticed, because I'm from Kununurra, I've noticed there has been a big increase in mental health issues here in the Indigenous community. And if you don't work in these areas that I work in, you probably don't see it or realise it is a great deal.
It allows the local health workers access points for training and further development of their skills in dealing with a multitude of drug and alcohol issues, serious mental health conditions such as depression and schizophrenia are sometimes also dealt with. But their main drive is to provide a platform for the OVARS clinic to refer those issues which are going to take a lot longer than a simple GP consult to sort out.
Something like that, close to a garden.
Yeah. Well, how many days a week you do? Every day or every couple of days or once a week or what?
Twice a week or something.
Twice a week, alright. My job varies in all areas. I do with the alcohol side of things, my clients out there. I do one-on-one, also group sessions and referrals to the rehabs. That's any rehab in West Australia, but I mainly work through Wyndham, the 7 Mile rehab there, or Millimara down in Broome.
Our main work is to actually case manage people, and we work with them to fulfil their goals. Basically, we're very, very much goal focused. As well as this, we also go out to communities and do educational activities. One particular community that we've responded to who had several suicides, we are working with the school children, and we've run programs with them about alcohol abuse and how to sort of like cope with, you know, situations in their own home. We've started a women's group there. We're starting up a men's group there. We've worked with community members in drug and alcohol, but we still have our caseload that we actually manage people and do the goal setting and everything else on an individual and family basis.
Yeah, we do go out. We speak to a lot of people and do help them to understand that they're unhealthy and they do need to go see doctors. Or in other cases, they are very depressed and don't want to do anything. You know, the family contacts us and we go out there and see them. And help them to come into the clinic. And that helps the GP and the main clinic line on the side.
The main issues, very much alcohol is the main issue that people get referred to us. Sometimes the person might come because of a domestic violence or a relationship problem that they want to work through, but you can be pretty well assured that at the bottom of that there will be some sort of substance abuse. So alcohol and marijuana smoking are really big problems, but we do have people come for other reasons, but usually it sort of works back to that as well.
They do a lot of work in the community. They do a lot of work with the schools. They're working currently with the people who are soon going to be opening the new youth centre, and talking about what programs they'll have there. They also go out to some of the remote communities.
I do the Warman community. I do a lot of alcohol and drugs there and counselling for grief, because there's been a lot of dramatic things that happened over there in the last 6 months. So I do a lot of work over there as well as Wyndham and Kununurra. So we're pretty well known here now, and the community, if they see one of their families or friends having a hard time, can't cope, they contact us. We'll see them. If not, if they're a bad case, we'll refer them into our doctors. And also the clients that do come through the GPs next door here, the doctors, they'll refer them to us, and we'll further do the counselling and carry on. We'll do a lot of follow-ups, going out to see them weekly, if need be every day or every second day.
It ties the local people or the patients in with an ongoing, continuing support unit, basically to help the people get to the drug and alcohol rehab that they need to, as a touching point for a place where they can discuss the domestic violence issues, a place where the school can contact for the drug and alcohol issues that are faced by the school. That's the concept of the social support unit, running very closely alongside the OVARS clinic.
Well, normally a referral from next door would come from the health workers, doctors or nurses, and usually they'd ring over and sort of give us a bit of a background or whatever, and see when we could actually see a client. Hopefully we can see them pretty well straight away, because often with Aboriginal people, once they go you might lose them, and when they're actually there and they want help, it's good if we can respond pretty quickly. So they'd actually ring up, talk to us, give us a bit of background and everything else, and then either send the client over to us or refer in a way that they didn't want to move from the room they were in. We'd actually go over and have a chat to them, and then we get a paper referral as a sort of a follow-up for our records.
We can refer straight to them, we can take people over. They can then come back and talk to doctors if they're concerned and want medication, or so just again having everything in the one place is hugely beneficial, and having them seen so much in the community is great for the health service as a whole as well.
If you ask about domestic violence, it is there. If you ask about alcohol problems, they are there. And it's very easy to kind of sweep them under the carpet and go, oh, can't do anything about them, so why ask? Social support is ingenious, and it's being placed next door to a medical clinic because it allows those questions to be asked and an avenue to be pursued when the answer is yes.
Having the social support unit next door increases our ability to give complete, holistic, best practice care to every client. I suppose before they were there, anybody that was seen that, either had a obvious mental illness or, maybe had something a bit underlying that you just really wanted somewhere you could send them with someone that was trained that could do it. The only options were the mental health unit, which is a government-run unit that, as every health service, is always understaffed, has a bit of a waiting list. It's in a separate building that everybody knows that's the mental health building. So a lot of people would not want to go. It's also something that you think, well, if I'm not going to be able to get them in straight away and I can't really offer them anything straight away, do I even bring it up? So having these guys here is fantastic. I mean, even with things like drug and alcohol, it's almost impossible to get a bed in a rehab in this area. So again, if somebody was talking to you about it and you were worried and thought they maybe should go to rehab or they maybe should go to detox, there's nowhere really to send them. The hospital doesn't have the available beds or the ability to cater for that. The mental health team didn't have, anywhere specific they could send people either. So having these guys next door just means you can look at every aspect of every client and you've got somewhere they can go on site.
It's something that Kununurra really needed for a long, long time. A lot of people didn't want to go to the North West Mental Health because they don't like the word mental, because I've been working for North West Mental Health before, and every time I go out to see somebody, I never ever use that word mental because that turns them right off. But today, the community out there now, they just seem more relaxed when we go in there to speak to them, and they will open up and talk to us about most of the problems that they are having. And I think, like I said, it was really needed in Kununurra and the surrounding areas, and I see it opened right up in a big way,
The people that come to see us at OVAS come for the boils, but if you screen, for the diabetes, screen for the hypertension is there. Just the same with mental health issues. If you ask the right questions, you'll discover the sleep problems, the alcohol problems, the domestic violence issues. They are all there if you just ask for them, but having that avenue to go, right, there's someone that can help you that's culturally appropriate. It's from a general practice perspective, I love working in an Aboriginal health organisation for that reason. It's teamwork.
You're right. But I've got a booking for you for next week again.
Yeah.
So come on then, You know?
Yeah.
I'll take it easy.
Now, not everyone, of course, has a social support unit across the hall, but again, there are some potential lessons for us here. Firstly, to simply be mindful of the issues your Indigenous clients may be facing, but also to be ready. Know exactly what services might be available so that you're free to ask the question, knowing you have an outlet if the answer is yes. Well, that's it for this evening. Don't forget, if there's any part of this programme you'd like to review at a later time, a delayed transmission of the Rural Doctors programme will be available via internet web streaming next week. Now, this service is accessible through the Rural Health West website at www.ruralhealthwest.com.au. And do note that the internet transmissions are password protected, so if you haven't already, you'll need to register by contacting Rural Health West. And do be warned that this service works best for those with high-speed broadband. We'll be back again on the 1st of July with a programme that focuses on the medical implications of working closely with animals. We look forward to your company then. A big thanks to everyone who took the time to be involved in our programme tonight. And thanks to you for taking the time to join us. From everybody at Rural Health West and the crew here at West One, Jerry Gannon saying good night and thanks for being with us.